Hysteria by Jones HMMBADMS. This is a neurotic mental illness that is characterized by emotional attention seeking from those that they want to win sympathy. Hysteria can be described as a type of psychoneurosis, minor mental health problem, causing emotional excitability, such as fear, panic or disturbance of the sensory, motor and psychic functions of human beings. Hysteria is further described as an overwhelming and unmanaged excitable behavior without any organic basis or cause. The term hysteria is no longer used widely, but dissociative disorders and conversional disorders, or somatization and histrionic personality disorder. Despite extensive research on patients with hysteria, no neurological evidence for the disorders has been conclusively found. Therefore, a psychiatrist is the best person to diagnose and treat hysteria. Epidemiology. It is more common in females than males. It is now less seen than 70 years ago, when it was frequent in people. Evidence from clinical experience suggests that pain and the simulation of bodily disease are the predominant forms of hysteria now manifested by patients. Etiology. Past traumatic conflict or experience. Undue stress. History of past abuse. Repression of sexual or aggressive behavior. A fixation in early psychosexual development at the level of Oedipus complex, with a failure to relinquish the incestuous tie to the loved parent, leads to a conflict in adult life over the sexual drive because it retains its forbidden incestuous quality. The drive is then subjected to the defensive psychological maneuver of repression. The energy derived from the drive is converted into the hysterical symptom, which not only protects the patient from a conscious awareness of the drive, but often provides a symbolic expression of it. Hysteria is conceived of as a specific clinical entity arising from specific sexual conflicts originating in the Oedipal period of the psychosexual development. It is difficult for patients with hysterical reactions to stop their symptoms, partly because for them to do so subjects those to the mental discomfort associated with being aware of the forbidden impulse. Moreover, the symptom itself can bring certain advantage to the patient. It defines him or her as a sick and disabled person, and the people in his environment act accordingly. Therefore, attention, sympathy and help are focused on the person because he or she is ill and is not supposed to carry out the duties and responsibilities expected of healthy adult or person. Such advantages gratify the dependence needs of the patient and tend to reinforce the perpetuation hysterical symptoms. In the mixed neurosis, the hysterical symptom is only one of a repertoire of clinical manifestations that may include phobia, obsessions, compulsions, and exogenous depression in which psychogenetic factors are primarily pre-Oedipal and pre-genital. Hysterical symptoms are found in a variety of personality types, such as the passive-aggressive, schizoid and paranoid personality in which, according to Freudian theory, pre-genital conflicts play a predominant role in causing hysterical reaction. It has long been known that hysterical symptoms may result from frightening physical accident that has produced no bodily injuries. The primary motivation for these symptoms is self-preservation rather than Oedipal genital drives. That is to say, the symptoms enable the patient to escape a dangerous situation, to be relieved of onerous responsibilities, and to receive attention, protection and help most desired. These unconscious dependence needs are a source of conflict for the patient since they run counter to the image of oneself as a strong, self-sufficient person which he or she must preserve to maintain his or her self-esteem. Types of hysteria. A. Single individual monohysteria. This is when the hysterical symptoms and signs attack one person at a given time. B. Mass hysteria. This is the attack that affects more than one person at a given time. Phases of hysteria. I. Conversional or physical phase. This phase of hysteria must be distinguished from psychophysiological disorders which are mediated by the autonomic nervous system, from malingering, which is done consciously, and from neurological lesions, which cause anatomically circumscribed symptoms. Manifestation of conversional phase. Nausea and vomiting. Abdominal pains. Loss of libido. Impotence. Partial paralysis. Temporal blindness. Abdominal muscle cramps. Involuntary eye movements such as rolling the eyes inwards. Specific female physical symptoms. Faintness. nervousness, increased or reduced libido, fluid retention, heaviness on the abdomen, shortness of breath, muscle spasms, insomnia, irritability, poor appetite, i.e., dissociative or mental phase. This is the form of hysterical neurosis in which alterations of patient's state of consciousness or identity to produce such symptoms. The primary manifestations are mental or central nervous system involving, in that the sufferer depicts mental symptoms. The various forms of dissociative hysteria begin and end abruptly. The patient rapidly goes into a somnambulistic state, or he suddenly becomes aware that he has lost his memory for a period of time in the immediate past. Manifestations of dissociative symptoms. I. Somnambulism. Here the patient exhibits altered state of conscious awareness of the surroundings. The patient develops vivid hallucinatory recollections of emotionally traumatic events in the past, of which he may not recall in his normal awake state. This state may occur during sleeping or waking up hours. This should not be confused with episodes of sleepwalking seen in children. In somnambulism, the patient is out of contact with the environment in that he or she looks preoccupied with a private world and may stare into space or air if eyes are open. Patient seems upset, would speak words and sentences that are frequently hard to understand, or be involved in a pattern of seemingly meaningful activities that is repeated every time an episode occurs. This behavior usually represents the external manifestations of a hallucinatory re-experiencing of a traumatic event whose memories are normally repressed. There is amnesia for the somnambulistic episode once it is terminated. I. Amnesia. In localized and general amnesia, the patient suddenly becomes aware he has lost a total loss of memory for the events of a period of time covering anything from a few hours, localized form, to a whole lifetime of experience, general form. The amnesic patient gives no indication that there is anything wrong and seems entirely alert both before and after the amnesia occurs. In systematized amnesia, the patient loses memory only for specific and related past events. The patient with continuous amnesia forgets each successive event as it occurs, though clearly alert and aware of what is going on around him. Fugue. Here the patient wanders away from home and for days at a time. During this time, patient is completely forgetful of his past life and associations, but, unlike the patient with amnesia, he is unaware that he has forgotten anything. When he comes back to his former self, he recalls the time antedating the onset of the fugue itself. Unlike those in somnambulistic state, the patient in fugue does not behave strangely, nor does he give evidence of acting out any specific memory of a traumatic event. On the contrary, he leads a quite prosaic, seclusive, or solitary, works at simple occupations, lives modestly and does nothing to attract the attention or suspicion of the neighbors or friends. If multiple personality. In this phase, the patient is dominated by one of two or more distinct personalities, each of which determines the nature of his behavior and attitudes during the period that it is uppermost in consciousness. The transition from one personality to another is sudden and dramatic in occurrence. There is generally amnesia during each state for the existence of the others and for the events that took place when another personality was in the ascendancy. However, one personality state is not bound by such amnesia and retains complete awareness of the existence, qualities, and activities of the other personalities. Each personality is a fully integrated, highly complex set of associated memories with characteristic attitudes, personal relationships, and behavior patterns. The patient shows nothing unusual in his mental status. Morbid personality. Histrionic personality presentations. Tendency to dress immaculately and provocatively. Talk about their emotions in an exaggerated fashion or manner. They are usually shallow, self-centered. They are unhappy when they are not the center of attraction. Diagnosis of hysteria. A physician should take a thorough history of the symptoms causing concern to the patient, after which there would be a thorough physical examination. Involve a psychiatrist or psychologist to evaluate and assess the patient. It should be borne in mind that it is important to understand that the patient is disturbed and wants the problem to go away, even if there are no abnormal findings and not faking. Investigations. FBC. MRI. RPR. EEG. Stool. Urine. CT scan. Dopamine, serotonin, noradrenaline. Management. It should be clear that drugs play very little role in treating the hysterical patient. However, if there are any features, then attend to them accordingly. Antidepressants if there is depression. Anxiolytic if there is anxiety. Painkillers if there is headache, backache or body pains. Psychotherapy is most advisable in helping an hysterical patient. Patients should be encouraged to go through life daily with a positive attitude. In case of a sexual dysfunction in a female, massage of the genitalia by the psychiatrist or physician, and then later on use of vibrators and water sprays to cause orgasm can be done. Precautions against frequent hysteria attacks. Avoid extreme change in climate. Hysteria can be aggravated when it rains too heavily or too cold. Avoid disclosing very shocking news to the patient. Give the patient love, care and attention because they are always feeling neglected. Always keep cool and composed when dealing with such a patient. Never retaliate with a patient who has hysterical attack because patient may be violent. When the attack has cleared, try to comfort the patient with soothing words. Physical touch is necessary and expected because the parasympathetic system stabilizes the patient. Give juices or plain water to regain composure. Do not give coffee or tea because they aggravate the attack further. Give soft food, not dry or fatty food to an hysterical. Do not give dry fruits, chocolates, but fresh or watery ones like watermelon, mangoes. No smoking at all. Complications. Severe tear on the heart due to great level of attacks. Stroke and heart attack due to attacks. Brain malfunction due to asphyxia. Permanent paralysis may occur due to hysterical attacks.